And yes, Kelly, if you could go ahead and resend the confirmation email, that would be great. Oh, if you haven't already done so, go ahead and put your name, your location, and your pronouns in the chat. We are so glad to have you joining us today as we are getting ready to talk about the ABCs of USCHA. I'll go ahead and give it just another minute for people to join. We are recording so that if something comes up and people aren't able to join us, that they can go ahead and listen to the recording ahead of our USCHA next week. All righty. So we have a packed agenda, and I'm going to go ahead and get us started. So welcome, everybody. We are so glad to have you with us here today for our ABCs of USCHA. This is intended to be an advocate's guide to USCHA to really help people come to Washington with a good foundation around both what the federal programs are and how we can advocate and demand to have attention paid to events and to agencies and to programs that we know are critical in the life and well-being of people who are living with HIV. I'm Barb Cardell. I'm the program director with PWN USA. We have a number of presenters, and we're going to go ahead and just get started. Let's see here, our logistics real quick. We are recording our meeting. We are in meeting mode, so if you could keep yourself muted, that would be great so we can get a good, clear sound quality for folks who want to listen in later. Feel free to ask questions in the question and answer or actually in the chat, and we will go ahead and lift them up when we have time for questions at the end. And again, please go ahead and introduce yourself, your name, your pronouns, and where you're at in the chat, because we are so glad to have you here and we want to know everyone who is in this space with us. A little bit about PWN. PWN is the only national organization that is led by and for women living with HIV. And when we say women, we say all women, including transgender and cisgender women. We have been around since 2008, so we are 15 years old, and we are really proud of that. PWN was founded by diverse women, 28 diverse women who were living with HIV. And we came together in a response to a need to ensure that the voices of those who are most impacted are part of the decision making. And so we have 3,000 members nationally, and we have a number of chapters as well as state leads who are helping us ensure that members and women living with HIV in all of these states are able to advocate, engage, and make sure that the lived experience and the expertise of our folks are elevated. Our mission is to prepare and involve all women, trans and cisgender, gender diverse, and transgender folks living with HIV in all of our diversity in all levels of policy and decision making. So we are an advocacy organization that works to really empower and advocate for our needs. And USCHA is one of the most critical opportunities for us to be able to do this. It is in Washington, D.C. this year, and so we will have access and opportunity to talk to a lot of policymakers and leaders, including ourselves. Our agenda today is that we're going to go over the main executive agencies so that people can see how they fit together. We're going to start at the top and work our way down to the agencies. And then we're going to talk about what are our issues, do a quick overview of those so that people will have some talking points, as well as a little bit of clarity about when we talk about why these are so important, why they are so critical for us. And then finally, as always, we'll get to our demands, which is how we're going to hold people accountable and how we are going to show up and advocate. Our objectives for today are, as we have mentioned, once again, to prepare and empower people to be present and advocate at USCHA, to have a clear understanding about how all the pieces fit together around federal agencies and programs, to talk about current concerns that are highlighted by people living with HIV, especially women, cis, and trans who are living with HIV. Talk about some of the issues, molecular HIV surveillance, status neutral, ending HIV criminalization, Ryan White funding challenges, and then finally to have everyone who's been on here to feel really empowered to step up and ask questions. Because sometimes, even though we have the experience, even though we have the expertise, we sometimes feel as if our voices are not important. And if you leave with only one point from today's webinar, please know that the voices of people living with HIV are the most critical voices to be heard at conferences. They need to know how programs impact us, impact our communities, and impact our lives and the lives of the people we love. And without that input, decisions are made that actually can be very damaging. So that is the one piece. If you don't remember anything else from our time together today, please remember that our voice and our input is critical. Here are our presenters today. We're going to go ahead and ask them to introduce themselves as they are starting to talk about their particular area. As we have mentioned, we are packed with all sorts of good stuff to talk about today. But here are our presenters. And with that, I'm going to go ahead and pass it over to Martha to start talking about our federal government.
Hi, everyone. I'm so excited to be here and so excited to be welcoming you to Washington, D.C. for the USCHA, which becomes like really, really important for you to use every opportunity to advocate for our community. So my name is Martha Cameron. I am the vice chair of the People Living with HIV Caucus, and I work for and absolutely proudly associated with many of the anchor networks that are part of the HIV Caucus. But I'll tell you one thing. I'll put a plug in for the PWN fellowship that I was a part of, even after many years of working in this field, because this is where I really got to learn and understand this information about the federal government, even though I'd been doing policy and advocacy for a very long time. So let's jump into it because we have a lot. So we know that the Constitution established the separation of powers, 3 but very equal branches, the legislation or the legislative that makes the laws and is comprised of Congress and the Senate and House of Representatives, which is very important. And at another day, we can, really understand what that means, especially as we go into next year. We have the executive, which carries out the law. So they are the implementers of the law. And of course, that is made of the president, the vice president, and the cabinet, which we'll be looking at today. And then there's the judicial, which interprets the laws, right? And we have heard of a lot of things that have happened in the Supreme Court or are happening in the Supreme Court because they're basically in charge of interpreting the laws, the federal laws that end up governing us. And this becomes very critical, especially when you see, for example, some of our sexual and reproductive health rights being decided at this level. So this is important. But for the purposes of this, we're going to focus on the executive branch and how it relates, especially to our HIV community and what we need to be advocating for. And please, next slide. And in case somebody's sort of asking, well, what does this have to do with USCHA? Well, you'll be walking the halls of a place that is very close to where all of these people work. And a lot of them do show up at workshops and at meetings over there. And you want to use every opportunity to be able to speak up about some of the issues that we're demanding for. I'm not going to read through all of this, right? We have various departments that make up cabinet: agriculture, commerce, defense, education, energy, as you can see on here. For the purposes of our discussion and for what we're trying to achieve today, which is some of the departments that are directly or indirectly associated with our community and with HIV, we're going to be looking at the Department of Health and Human Services, the Department of Housing, and Urban Development, the Department of Justice, and the Department of Labor. Next slide, please. All right. So the Executive Office of the President, I think we all know who our president is, President Biden and Vice President Kamala Harris, houses the Office of National AIDS Policy. And the Office of National AIDS Policy plays a really key role in the policy that is related to HIV and AIDS. They are directly under the Office of the President, and they directly advise the President on issues relating to HIV. Thank you. So ONAP is part of the White House Domestic Policy Council, and currently is actually unfunded through HSS, which really begs a question about how HIV is being prioritized. Just a little bit of history. The National HIV/AIDS Strategy, it's right there. This office develops and implements the President's National HIV/AIDS Strategy, which was first implemented under President Obama's administration. And before that, there had been no national HIV/AIDS strategy in the US. All the other countries globally, and I get to know a little bit about this because I'm an immigrant, everybody before they received US money was charged with having a national HIV/AIDS strategy. We did not have one. And until, until the advocates and everybody spoke up, we would have never had a coordinated and integrated approach to prevention, care, and treatment that has been established by the National HIV/AIDS Strategy, establishes benchmarks in terms of data that we're supposed to achieve, and so we can be guided by that. So ONAP also partners with the National Security Council and the Global AIDS Coordinator to respond to the global world through PEPFAR. And I hope some of you have heard what is going on with PEPFAR as well. We won't talk about it in depth today, but we've really got to be aware that, some of the issues that we fight for also impact global AIDS policies. Next slide. And Rob, just let me also know, please chime in if I've missed anything that you want me to say, my co-presenters. So these are the main executive agencies that affect HIV programs and policies. It is the Department of Health and Human Services, the Department of Labor, the Department of Housing and Urban Development, and the Department of Justice. So we'll go into a little bit for each one. Department of Health and Human Services is, I think, one of the biggest ones that houses so many of the agencies that we end up hearing about. We all know, for example, maybe we've heard about HRSA. And I actually used to think HRSA was a department in itself, because that's where the Ryan White program is housed. But it is not. HRSA is one of the agencies that falls under the Department of Health and Human Services. The CDC we've heard about, since it's the Center for Disease and Control and Prevention. That's also housed under HSS, and we'll go through each of these departments. But just to get the sense that all these big agencies that we saw, Centers for Medicaid, the NIH, and the Administration for Community Living, which is associated with aging, all these are housed under HHS. Really, really important. Next slide. OASH, or the Office of the Assistant Secretary for Health, leads the HIV epidemic response through the Office of Infectious Disease and HIV/AIDS Policy. So ending the HIV, which was started, I believe under the Trump administration, and has its issues that we're going to talk about, is housed under OSCHA. It has overall project coordination and management. It monitors the progress and delivers information through hiv.gov, which is a huge online platform. This also includes the Minority HIV/AIDS Fund that improves prevention, care, and treatment for racial and ethnic minorities, and essentially is supposed to help end some of the disparities that we see, especially as they are related to race, as we know, race and gender. So that's OSCHA, leading the HIV epidemic response. Next slide, please. CDC, I'm sure we have heard a lot about this. The CDC is supposed to maintain a focus on prevention, which can often manifest itself in language and actions that can be stigmatizing and harmful for people living with HIV. A biggest example of this is how they define their response through behavior and risky behavior, and populations are defined in different ways. And this is where surveillance also happens, and we'll hear a little bit about this, which can be very problematic. But this is where it happens. Anything to do with prevention. The National Center for HIV/AIDS, viral hepatitis, STD, and TB prevention is also housed under the CDC. And this is where you see mini versions of this in health departments across the country, where they will always have a department. For example, in DC, they have HASTA, which essentially deals with HIV/AIDS, hepatitis, STDs, and TB prevention. This would be the overall agency that is supposed to deliver HIV prevention and programming guidelines. Next slide. The Health Resources and Services Administration, so HRSA, is very important to us because this is where the Ryan White is housed. So under HRSA, there is a Bureau of Primary Care that deals with all other primary care. And then there is HAB, which is the HIV/AIDS Bureau. And that's where the Ryan White program that serves about half of the people living with HIV lives. And the Ryan White program has different parts. Parts A, which are implemented through TGAs and EMAs. Part A's are also where you have planning councils in the various EMAs that will have the jurisdictions to have a planning council. But Part B is implemented through the various health departments across the country. And Parts B are also supposed to have some kind of planning body or consortia, whereas in Part A, it's mandatory for the planning bodies to have at least a third of people on them living with HIV. Part B only suggests that they even have any planning bodies. And we have been finding, as we have been interacting with folks, that the health departments are even either shutting down, obviously maybe using COVID as an excuse, but even before that, there are certain jurisdictions that only have Part B through the health departments and have no way of advocating for the health, for the HIV services. Then there's Part C, Part D, and I believe there's a Part, I thought there was a Part E too, but I know Part F, for example, is where there are AIDS education training centers. So that's meant for training. If you haven't heard already, we really need to understand that our Ryan White program is under attack right now. And so part of what we're even going to try and do at the USCHA is ensure that we can advocate. We should be able to speak about this service, and we're also going to protest. And I think we'll talk a little bit more about that in terms of our action items, but we really need to understand that Ryan White services, which are meant specifically for HIV positive people, are in danger both by being taken over by prevention services that they want to braid or integrate in terms of infrastructure when they have been inadequate, even for people living with HIV, but also just in terms of funding. And this is where I said we need to pay attention when it comes to voting next year, because this is really critical as to how this is being done. Next slide, please. ADAP, also really important, administered under the Part B of the Ryan White program, is how people get their drugs. So the AIDS Drug Assistance Program was put in place, and it helps to provide the medications then to low-income people living with HIV who have limited or no health coverage from private insurance, Medicaid, or Medicare. So you could be receiving care, health care through a Part C hospital, for example. You could be receiving support services from organizations that receive Part A and provide non-medical case management, but most likely your medications are through an AIDS drug assistance program. And you find that even in this day and age, sometimes people are on a waiting list for their drugs on this AIDS drug assistance program. So it's important for us to keep advocating for ADAP, because this is the only way we can get medication to people who may be ineligible for insurance. Sometimes it's used for co-pays. Sometimes it's even used to purchase insurance for those that may be eligible to get, for example, some of the insurance on the marketplace. Next slide. Centers for Medicare and Medicaid, also really critical. We know that over 1 million people, 1.2 thereabouts, are living with HIV. And most of us, let me say, and I didn't say this in the beginning, most of us are low income or of a certain socioeconomic. If you're not getting your care under Ryan White, you're probably getting it through Medicare and Medicaid. So it is truly the single largest source of healthcare for people living with HIV, and especially for those who are 65 and older. Next slide. The administration for community living, really important. Purpose is to be able to maximize the well-being of older adults. And very recently, there's been advocacy to ensure that the Older Americans Act includes support that has been needing updating so that it can include support and protections for LGBTQ plus and older adults who face additional stigma and additional challenges when trying to access services for people aging with HIV. So this is really, really critical. Next slide. Yeah, and so this was what we just talked about here, the HSS, and we have just described all these agencies that fall under HSS. I didn't talk a lot about NIH. It's very important. That's research. Everything that we do related to HIV and AIDS, all the research goes through the NIH. And I just wanted to make sure that we recognize that it's a part of this. But all these other agencies that we spoke about are under HSS. Next slide. Housing and urban development, really critical. We know that housing is treatment. And that is where HOPWA, the Housing Opportunities for Prevention with for people with HIV, is housed. We know that it's inadequate. We know that it needs updating, but that's why this department is important. It houses HOPWA. HOPWA did get an increase, but still needs a lot of attention and advocacy to ensure that people can be getting not just affordable, but decent housing as people living with HIV. Next slide. Yeah, the Department of Justice, really important for us. I think a lot of us on here have heard about criminalization. If not, let us know. And we'll make sure we get information to you. But this is one of the most important, especially as it relates to our community, that is over policed and over surveilled. So the Department of Justice plays a really important role in issues relating to HIV and AIDS. Next slide. And the Department of Labor, really critical. The Department of Labor houses the Office of Disability and Employment Policy, which takes into consideration people living with HIV. Initially, it used to be treated as a disability. At this point in time, the Department of Labor only has a toolkit and some other resources online, and there's a lot more work that needs to be done to ensure that people living with HIV have access to employment services as well as employment counseling. And we know that one of our anchor networks works a lot in benefits, ticket to work program. So please pay attention to this. And if you need more information, we'll have our anchor networks, I'm sure, talked about at the end of this meeting. Next slide. Okay, I'm going to hand over now, but except to say real quick, please watch out for any people that represent these departments at USCHA. Sometimes they're in uniform, or you can go as far as asking when you're in a workshop, just put up your hand and say, you know, before I ask my question, I just want to know, is there anybody from, you know, the Department of Labor or the HSS from here, so that you can make sure you provide targeted comments to people who actually impact our services. I'll hand over now. Thank you.
Thanks, Martha. And let me introduce myself. I am Ronald Johnson, and I serve as chair of the U.S. People Living with HIV Caucus. And I'm going to follow up, Martha, that in addition to the departments and the agencies within those departments that Martha walked us through, there are numerous federal advisory bodies within the federal government. And two of those bodies directly impact HIV and AIDS policy. The Presidential Advisory Council on HIV/AIDS and CHAPA, the Advisory Committee on HIV, Viral Hepatitis, STD, and Treatment, are betterwise or shortly known as CHAC. But first one we'll focus on, and I'm sure many of you have heard or are familiar with, the Presidential Advisory Council on HIV/AIDS, PACHA. And this is a body that provides information, recommendations to the president through the Secretary of Health and Human Services regarding the programs, policies, and other issues, research, treatment, prevention on HIV. It's designed to be the primary advisory body, again, to the president, but reporting through the Secretary of Health and Human Services. The PACHA is mandated to have a maximum of 35 members who serve for 4-year terms. It should be noted that there is no requirement in the PACHA charter for there to be members who are people living with HIV. There's language that says it's, you know, urged or occurring, but there's no specific mandate to have people living with HIV as members of PACHA. Now, currently there are several members of PACHA who are people living with HIV, and to my knowledge, there has always been people living with HIV on PACHA, but again, there is no mandate specifically to have people living with HIV on PACHA. PACHA meets about 3 times per fiscal year, the fiscal year being from October through September. So this is the last month of the current fiscal year, FY23. So PACHA has about 3 meetings. The next meeting is going to be September 20th. And it will be held in Charleston, West Virginia. And the focus of that meeting is on HIV in Appalachia. All the meetings are open to the public and they are live streamed. So you can go on the website for PACHA to get the link for the live streaming. Or if you're going to be in the West Virginia area, you can hop into at the meeting in Charleston. Next slide. The other advisory body that we want to focus on is CHAC, the Advisory Committee on HIV, Viral Hepatitis, and STD Prevention and Treatment. And this is a body that is co-administered by the CDC and HRSA in light of the overlapping areas of prevention and treatment. The CHAC addresses the issues and develops advice to the HHS secretary, the administrator of HRSA, and the director of the CDC on objectives, strategies, priorities, focusing on HIV, viral hepatitis, and STD prevention and treatment. It is mandated to meet around 2 times a year. It is made up of 18 members, but unlike PACHA, there is the mandate that at least 4 of the members must be people living with HIV. Next slide. We also, in addition to the departments, the advisory bodies, we want to highlight 2 government-wide policies and programs dealing with HIV. The first is the Ending the HIV Epidemic. And this is, next slide, an operational plan that has been developed by HHS agencies and focused on achieving the goal of ending the HIV epidemic by 2030. And this initiative focuses and zeroes in on prevention, diagnosis, treatment, outbreak response. These are the pillars of the Ending the HIV Epidemic plan or initiative, again, aimed at the goal of ending the epidemic by 2030. One of the main issues that many of us in the community have around the ending of the HIV epidemic is the almost what I would say myopic focus on biomedically interventions. And many of the issues that the caucus has raised and other people living with HIV networks around the quality of life are not often focused on and reflected in the Ending the Epidemic. It is very much focused on biomedical interventions. There's a reliance, what many of us consider over-reliance on MHS, and not taking the concerns of the community around molecular HIV surveillance, that's MHS. And there are no clear structures and pathways to ensure the meaningful involvement of people living with HIV and AIDS, MIPA. And it does not include key communities that are impacted by HIV, like sex workers and immigrants. Next slide. The Ending the Epidemic initiative has, in its first phase, and we're currently in that first phase, 48 jurisdictions that have high burden. These are high burden counties, including Washington, D.C. and San Juan, Puerto Rico, that have a high burden of HIV. In addition to the 48 counties, there are 7 states that have high rural burden of HIV. And these jurisdictions make up the Ending the Epidemic initiative. Next slide. The other government-wide policy, and again, I'm sure many, if not all of us are very, very familiar with, is the National HIV/AIDS Strategy for the U.S. that has been updated for 2022 through 2025. We refer to it by the acronym NAS. And this highlights the strategy, the government's strategy for ending the epidemic. One in the implementation plan that was released, I think last year, there was an increased and explicit focus on advancing racial equity. The update, and again, I think really the result of strong advocacy from the caucus and people living with HIV networks to include quality of life. And the implementation plan highlighted 4 indicators for quality of life that include structural and social determinants of health, including, for example, work and the importance of employment as a factor in determining quality of life. We do have continuing concerns with the strategy around, again, its focus on using molecular HIV surveillance and cluster detention in the response to HIV. So MHS and CDR, cluster and detection response, are real issues that the community has, and we will continue to raise these issues. We also have concerns about what the growing reliance on status neutral within the National HIV/AIDS Strategy and throughout, increasingly, the federal response. And this is a real concern. At USCHA, there's going to be an institute Wednesday that focuses on status neutral, and it's important. The caucus will have people on the panel, but it's going to be very important to raise our concerns, because status neutral approach, which is, from my perspective and many of our perspectives, vague, but really in its vagueness, the potential of threatening, and I use that word deliberately, threatening funding for people living with HIV and the programs that we need. And again, in other parts of the federal response, there's not a structured approach for MIPA, the meaningful involvement of people with HIV and AIDS. Next slide. All of which leads us to the Demanding Better agenda that was released 2 years ago. And it was and is the first comprehensive compilation of policy agendas and advocacy strategies by people living with HIV. And it's really, I think, I obviously have a bias, but this was a very real accomplishment, because it was the product of people living with HIV and looking at it from our perspective, and the perspective that those of us who are most impacted and the communities that have been most impacted by HIV are putting together an agenda. And we continue, this was meant to be a living document, and it continues to be one that we want to hear input from you and others in the community to further strengthen and make better our Demanding Better policy agenda. And with that, I will segue to some of the issues that we want to talk about at USCHA.
Awesome. Thank you so much, Ronald. And hi, everyone. My name is Kelly Flannery. I use she, or they pronouns, and I'm the policy director at Positive Women's Network. As Barb mentioned, Positive Women's Network is a national organization led by and for women, that's cis and trans women, and gender diverse people living with HIV in the US. Next slide, please. So over the next couple of slides, we're going to be talking about many different issues. The issue that I'm going to focus on is molecular HIV surveillance. As Ronald mentioned, MHS for short is actually one of the pillars of the EHE response. And so we as advocates, networks of people living with HIV, human rights advocates, have been pushing back against MHS for years now. So I'm going to take a little bit of time to explain what MHS is and what the concerns are that this approach raises. Next slide, please. All right. So what is MHS? You'll see on the screen that there's a definition from Molecular HIV Surveillance, a global review of human rights and implications. The link's going to go in the chat. I highly recommend that y'all check out that resource. It's amazing. But just to keep it short and sweet, MHS is a really controversial public health practice and research tool that has deep-rooted concerns for the human rights of people living with HIV, as I mentioned, that folks have been raising for years. If you want to think about it broadly, it really refers to practices that state and local health departments and the CDC use to identify HIV transmission networks by mapping out the social and sexual networks of people living with HIV. And this is really important, without requiring their knowledge or consent. In the US, MHS falls under this broader umbrella of cluster detection and response. And I'm going to put cluster in quotes. So when you hear someone talking about CDR, if you hear someone talking about it at USCHA or anywhere, I really want you to think about two things. First, people living with HIV are not clusters. Humans, not clusters. We are demanding person-first language when we're talking about this CDR practice. And second, oftentimes what we've heard is that people don't like talking about molecular HIV surveillance. Surveillance has been so deeply and intricately linked to policing and criminalization in the US and beyond that saying things like MHS is scary. And so to try to make it a little bit less scary, we've heard folks talk about it in terms of CDR. But CDR, to be clear, most oftentimes includes MHS. And so we really want to be clear and say, like, when we're talking about CDR, we're also talking about MHS, and all of the concerns that we're going to talk about in the next couple of minutes apply. Next slide, please. All right, so how does this actually work? I'm going to go over how MHS actually happens, and it starts with routine HIV care. Blood samples are taken from people living with HIV for drug resistance testing. This generally happens if someone's newly diagnosed, if they're switching medication, if they're starting a new medication, in order to make sure that that medication is suited to that person's needs. And during this process, a blood sample is taken, and that person's individual HIV strain is then genetically sequenced to determine if there are mutations that are resistant to HIV drugs. This sequencing really helps to figure out which medications are going to work best for people living with HIV. That's one section. That is a section where your medical information, your health information is being used specifically for your personal health treatment. However, without asking consent, without the knowledge of folks who are having these blood samples taken, this genetic data is also shared with local health department professionals and with the CDC. So public health officials actually analyze the genetic data, your genetic data, if you're a person living with HIV, to identify and track HIV transmission trends. Using this information, then state and local health departments can respond to quote unquote clusters of HIV transmissions, which are people living with HIV. This is CDR and MHS. The genetic data is also anonymized and aggregated and stored and made available to researchers and other members of the public subject to some limitations through research databases. One thing I really want to be clear here is that your genetic data is used outside of that person's medical treatment without knowledge or consent. And that's going to be one of the concerns that we're going to talk about in a little bit, about the issue of pushing forward the use of someone's medical information without their knowledge or consent. Next slide, please. All right, so where is this happening? MHS is happening across countries. It's also happening within different states in the US. And one of the things that we're going to talk about, one of the concerns, is that data sharing laws, privacy protections, i.e. whether or not your information can be shared with someone like the cops, and community engagement, how much MIPA is involved, differs depending on what state you're in, what country you're in. And in the US, the CDC requires that all US states collect, analyze, and report HIV genetic data gathered by medical professionals, and this includes your personal physician, in order to receive HIV prevention funding. So this means that even if your local or state health department thinks that there are ethical concerns, or whether the ethical concerns raised by MHS are worth the quote unquote benefits of it, they have to do this in order to receive that funding. And then this information is used for MHS to map networks of people living with HIV. Right? They are only able to do this molecular analysis because of the genetic information that's created by HIV drug-resistant testing, and it's used for reasons that folks do not explicitly consent to. Next slide. Okay, so I've kind of nodded to some of the concerns, and this is a really, really quick version of what we're talking about. Barb has put some longer webinars in the link that I highly suggest you take out for a much more comprehensive overview of the concerns and process that we're talking about right here. But just in brief, so as I've mentioned, MHS and CDR require no consent from people living with HIV. We talk about informed consent like it's supposed to be a cornerstone of medicine in the US. It really is a fundamental component of bodily autonomy that folks be routinely educated about the procedures and tests that are recommended by their doctor, and that they have the absolute authority to say yes or no. Historically, though, we know that that's not true. And this is especially true for BIPOC people, disabled people, people living with HIV who have experienced real harm and violence at the hands of the state from non-consensual medical treatment. Thinking a lot about things like reproductive oppression and forced or coerced sterilizations. This MHS requiring no consent is happening within a deeper context of medical violence. This is also happening within the context of HIV criminalization. Surveillance, as I mentioned, is linked to policing always, and this is especially true for BIPOC communities. Right now, 30 states have variations of laws on the books that criminalize people living with HIV, and there's not consistent data protections throughout the US. Data protections vary by state. So many states actually allow law enforcement to subpoena surveillance data with identifying information. And states where HIV criminalization happens, that data can be used against people. Some states even require health departments to cooperate with police and prosecutors. This is why one of our core demands that we'll go over in a little bit is that public health surveillance data be protected from use by police, prosecutors, and immigration enforcement. We also know that MHS and CDR can lead to inappropriate disclosure of personal health information and violence. The ways that HIV and the CDR and MHS have been reported in the public have been incredibly stigmatizing and dangerous in the ways that folks have identified neighborhoods and populations where rapid transmission of HIV is happening. MHS and CDR can exacerbate racial inequities and hamper public health efforts. We talked a little bit about medical mistrust and medical distrust in the ways that if there isn't a process of consent, that only exacerbates, makes worse medical distrust that has deep, deep roots in US healthcare. And there's no engagement or consultation with organized groups of people living with HIV before rollout and expansion. We have been clear about our demands for MIPA, and they have not been met in the ways that MHS have been rolled out, as is clear from the years upon years. People living with HIV and networks of people living with HIV have been trying to push back against MHS. Next slide. This is a document. It's an How to Talk About MHS guide that was created by the Center for HIV Law and Policy, CHLP, along with PWN and the caucus. I'm not going to say much about it, except please look at it. It has all the information for how you can feel comfortable talking about MHS and talking points that you can use if you hear public officials pushing back on it. Next slide. And over to you, Barb.
Great. Thank you so much, Kelly. So another point that you are going to hear, so you're going to hear molecular HIV surveillance or MHS and clusters all over the USCHA conference. And you're also going to hear a whole bunch about status neutral, because this is one of the programs that is being implemented both with the CDC and HRSA that unfortunately does not have a lot of feedback from people living with HIV, sounds really, really good, and is problematic in many ways. And so we're just going to give you a little bit of an introduction about it. We also have a one-pager that the caucus and PWN developed that talks about this, that also has some talking points. And Kelly will go ahead and put that link in the chat as we're going through. So as we talk about, status neutral is not neutral for people who are living with HIV. And the reason why we say that is because originally this was developed as a clinic approach, which is somebody would come in for an HIV test. If they tested negative, they would be linked into prevention care and services, have access to PrEP. If they were diagnosed with HIV, they would be linked into care where they were able to get medication, have access to health services. So that kind of approach within a clinical model makes a lot of sense, because it means that everyone is actually receiving good quality healthcare that meets their needs at that point in time. Where we start to get concerned is that in the last couple of years, status neutral has started to roll out both in state jurisdictional plans, requirements that are being communicated to states, as well as in a number of other programs. So when we talk about a status neutral approach, the approach is that both people living with HIV and people who are vulnerable to acquiring HIV are treated the same within our HIV service and prevention programs, which is great. We are not in a disagreement about that at all. We think that everyone should have access to all of the services, including housing, mental health support, access to quality food, all of these things that are part of the Ryan White program. We think those actually should be available to everyone as a basic human right to support people doing well. Unfortunately, when we talk about status neutral within HIV programs, there is not funding for people who are vulnerable to acquiring HIV. And so we are concerned about how this program is going to be implemented without taking away much needed services that are being provided for people who are living with HIV. And so when we go ahead and we talk about status neutral, it is really complicated, because we go back to that ending the HIV epidemic map, where additional EHE funding is being provided, but only to those phase 1 places, so those 48 counties and those 7 states. Other states like Colorado, where I live, are being told to implement a status neutral approach, but are not receiving any funding. And so we are very concerned that there will be an impact on especially the services that are provided for people living with HIV. Because this program was implemented without meaningful involvement of communities living with HIV, we have not been able to demand that they show us that these programs are not being impacted, and they are not currently being tracked. And so that is one of our demands that we have at USCHA at this institute on Wednesday morning. Hopefully people will be able to go ahead and join us to be able to demand that when we talk about status neutral, that we really do talk about it being an effective clinical approach, that we support the human rights and access to healthcare, as well as housing and other needs for everyone. And we demand that the needs for people living with HIV be protected within this system. And so we have our concerns for our community, and we just list them here. Really, we talk about ensuring that throughout the programming, that we must demand that the services, the units of delivery of care for people who are living with HIV are not impacted, and that they prove that. If they are implementing a status neutral program, either at a state or at a federal level, or even at a county or a city level, that they show where that funding is coming from, because we're starting to see some really tricky language where they're talking about the National PrEP Prevention Program using Ryan White infrastructure. So they're saying, well, we're not using funding, we're just using infrastructure, but the infrastructure is funded by the Ryan White program. And so we know that using it for the prevention part is going to impact the delivery of services for people living with HIV. So when we talk about status neutral, it is going to be so important that we really talk about our demands, as well as what we talk about being critical, which is that everyone should have access to these services. And with that, I'm going to go ahead and turn over the next piece to Ronald to talk about Ryan White funding and fully funding the HIV response. Sorry, Ronald, just want to check and see if you are available to come and talk to us about the Ryan White funding.
Yes, I am, Bob, and I'm here. Thank you. And this last issue that we want to talk about is a big one, funding, and specifically funding the HIV response, and highlighting the Ryan White funding and the kinds of cuts that have been proposed. Next slide. First, I want to step back and talk about the annual appropriations process. When we talk about the budget of the United States, that huge $1 trillion plus budget, in terms of the programs that fund the operation, it's called the discretionary dollars, and those are the dollars that are annually appropriated by Congress. Congress each year determines how much money will actually be spent by the federal government for what is called discretionary programs. And that's in comparison to the mandatory programs like Social Security, Medicare, Medicaid, that doesn't require annual appropriations. The government they're mandatory, so the government spends those dollars. But HIV funding is part of what we call the discretionary dollars. And these are the dollars, again, that are appropriated annually by Congress. And that process, that appropriations process, is broken into 12 bills. So it takes 12 appropriation bills to fund the operations of the US government, including the HIV response and programs such as Ryan White, HOPWA, and HIV prevention. The fiscal year of the government is October 1 to September 30. So if no appropriation bills are passed by midnight, September 30, 29 days, then Congress must pass and the president must sign what is called a continuing resolution, CR. And if that CR is not passed and signed by midnight on September 30, then the government shuts down. And we recently, a few years ago, we saw a government shutdown. So that is something that is really looming in these final months of September. And as we gather at USCHA, we need that will probably, and I hope will be, a topic of conversation. So I think it's important for us to be grounded in what the appropriations process means. And if there is not a deal by December 31, as a result of the Budget and Control Act, then mandatory cuts to discretionary spending will be in place, and that will include mandatory cuts to HIV programs. But that gives an overview of the annual appropriations process, which again is made up of 12 bills, including 2 bills that I would highlight: the Labor HHS bill, which includes much of the funding for HIV programs, including CDC, HRSA, Ryan White, and the Department of Transportation and Housing Development that has the HOPWA program. Next slide. But highlighting particularly the labor HHS bill that the House of Representatives and the current majority in the House of Representatives is working on includes drastic, I would say, draconian cuts for HIV. And that includes eliminating and zeroing out the ending of HIV epidemic initiative, which is for, in terms of what is current spending, by a $542 million cut. Drastic cuts to the Minority AIDS Initiative to the tune of $151 million. It eliminates, and again, I say eliminates funding for Part F of the Ryan White AIDS program. And Martha, again, outlined some of those programs that make up Part F, including dental programs, AETCs, the SPINS programs. All of this would be eliminated under the House's version of the labor HHS bill. And they also are calling for eliminating the teen pregnancy program to the tune of $101 million. In addition to these just abominable cuts that are being proposed, that bill also includes policy riders that are really harmful and hurtful and hateful to the communities that are so important and a so important part of the HIV community. Anti-trans policies, anti-Black and anti-abortion policy riders. This, I can't use polite language to describe how horrible this bill is and why it's so important for us to focus our advocacy around this. Next slide. And there is that contrast, and I want to, as an example of what's going on in Congress, there are two spending bills. Each house has to pass its version of these 12 bills. And the labor HHS bill, which again has so much of HIV funding, including the Ryan White program. The contrast between the House bill and the Senate bill is day and night. And while the Senate bill has a lot of flat funding, and we know in a time of just normal inflation, let alone high inflation, level funding is a cutback. But in this political environment, when we look at the kinds of cuts that the House is proposing versus the budget that the Senate is proposing in its bill, we see that we must advocate for Congress to at least use the Senate bill as a starting point. We will continue as a community and as advocates demand increased funding, but we have to forcefully say that the House bill, and I know these numbers on the screen may be small, but trust me, there are drastic differences between the two bills, and we have to advocate that the House bill is just unacceptable and that the Senate bill is a starting point for our advocacy and what we want. We have to avoid the drastic and draconian cuts that the House has proposed in its bill. But again, as I said, it takes 12 bills to make up the total budget. Only one bill, the House bill, for military assistance and Veterans Affairs has passed. So none of the bills have been passed by the Senate. The House still has 11 bills to work on and pass. So for the rest of September, we are very likely looking at a continuing resolution. So why is this important? Why is this important for the HIV community? Because again, if a continuing resolution is not passed, the government shuts down. And those services that we rely on can be curtailed and may not see an immediate effect, but a shutdown in the government does not work for anyone, including people living with HIV. So our advocacy for this month, when we're at USCHA and when we're talking to and writing and emailing, faxing, texting, whatever mechanism we use to contact our congressional delegations to say we must keep the spending in place. And in the meantime, we have to advocate for next year's funding to include adequate funding for HIV. And that starts with rejecting in its totality the House cuts that have been proposed. So with that, I will conclude and go into someone will be talking about our demands and our demanding better.
Thank you, Ronald. Michelle, I think we're over to you.
I'm here. Hello, everybody. I don't know about y'all. I'm a little bit unorthodox and being a part of this, so I'm just going to say it like this. We ain't got nothing to lose but our chains. It is time for us to begin to be about all the stuff we talk about all year long as advocates, as people who support the people that love us. You know, to me, first of all, let me go back. My name is Michelle Anderson. I'm the HIV policy associate for the AFIA Center. The AFIA Center is a Black woman, Black-led reproductive justice organization whose goal is to transform sexual and reproductive relationships of Black women and girls to address the mess such as this, right? To address the mess such as this. Because at the end of the day, all I see is policing of Black bodies. I see a lot of I see the ending of bodily autonomy as we know it, because they're coming for us. They are absolutely coming from us by any way, by any means necessary. And I'm telling y'all, this is a fight that we have no choice but to fight, or we are going to lose our right to be able to make decisions for ourselves, our bodies, our children, our family, where we work, where we go, what kind of insurance we're going to have, what kind of medical thing we're going to have. All those things this is what is going to happen if we do not do what is needed right here, right now, to end this epidemic for all of us, right? And so you can go on to the next slide, Barb, because I can go on for that. So one of the things we want to make sure we're talking about is this molecular HIV surveillance. This thing scares the hell out of me. I kid y'all not. This really scares me because as a Black woman, you know, living in the country of Texas, this puts me at risk for my HIV to be policed. Right. And so we want to make sure that we are having conversations, not just with, you know, the people on our local level, but also our federal government. We need to be calling the Office of NAP, HRSA, CDC, and PASTA. We need to be having conversations with them. We need to be knocking on the doors, because at the end of the day, they work for us. We don't work for them. They work for us, right? And we need to hold them to the fire. If they say they want to help end the epidemic, then we need to let's take a look at this together. This needs to be an inclusion of also people who are living with HIV, because I see that a lot of these laws and stuff that are being created right now is not inclusive of Black people, or not inclusive of people living with HIV, period. Right? So we need to go to our federal governments. We need to be having conversations at our state and health departments and our planning bodies. We need to be at the Ryan Wright council meetings. We need to be at those planning council meetings, having conversations as this. People need to know what's going on. And I'll tell you, I thank y'all for deciding to have this meeting today, because it is, again, this is crucial information, because by next year things can possibly look different, and they will in some way. right? We demand uniform and robust protection of data. We demand informed consent. I can't nobody get your stuff without informed consent, period. Period. Right? And meaningful involvement of impacted communities. Everybody who is impacted by this needs to be involved. There should not be, no longer be 6 people sitting at the table trying to tell other people how what's good for me and how I live my life living with HIV. Next question, next slide. We want to talk about status neutral, again, with the CDC and HRSA. I will definitely be on the webinar for the status neutral thing, because this is something that I don't have a lot of knowledge of, but it's still very crucial into how this work is going to roll out starting next year, how funding is going to look. And we demand specific tracking of services provided for people living with HIV before and after implementation, okay, of programs. Clearly identify source of funding used for SN program and meaningful engagement communities of people living with HIV and SN planning, most definitely. Next slide, please. And let's talk about Ryan White funding. We need to be having this conversation again, at the federal level with HRSA and of course our U.S. representatives and senators, and asking, what are y'all doing? What are y'all doing? What are we going to do? Y'all, last time I checked, when you took office, right, that was for everybody, not just some of the people, but for all people, right? And so we need to be having conversations with our representatives and our city council our senators, discussing what are we going to do to ensure that Ryan White maintains its funding, right? And that we continue to see an increase in funding to reflect increasing numbers of people living with HIV. Okay, next slide. Let's talk about ending HIV criminalization. Y'all already know what that's about, what that's all about. We definitely, they know what's going on. A lot of, we know that HIV criminalization is based on stigma. And we cannot, again, we need to have those conversations with ONAP, the DOJ, HRSA, outside planning bodies. We need to be talking about this, providing this information at Ryan White City, our council meetings, our planning council meetings, and of course with people living with HIV. And it don't have to be formal. You can sit up there, we talk to each other every day. You can pick up the phone and call somebody, hey, this is what's going on. At the end of the day, it's a fight that we are going to need in numbers, not just in face, but in actual numbers. We demand review and repeal outdated and damaging HIV criminalization laws and policy, any HIV criminalization and all EHE and state HIV plans, support services and programs for all parents living with HIV who choose to test and most definitely. Most definitely. Can we go to the next slide? And let's talk about housing for people living with HIV. We know housing is prevention. And so we need to be, again, having conversation on federal level with HUD and HAPWA, and then our demands are support safe, accessible and affirming housing, increase HAPWA funding to answer unmet needs, develop housing guidelines and support for independent living and nursing homes, support people living with HIV. This is pretty self-explanatory. And can we go on to the next slide? Did I run through them? Is this one me too? Okay, thank you, Barb. Let me move this out the way. We, again, if we are to have meaningful involve Black women living with HIV, this USCHA, we must listen to Black women. We've been telling y'all this for a long time. Black women got what you need if you just listen to what we have to say. Ensure that our voices are the loudest in the room, and support our leadership and help elevate the demands at the 2023 USCHA. Next slide. And then more areas to advocate. Is that me as well? Are we moving on? It's me too. Okay. More areas to advocate. I'm sorry, y'all. Protect and expand abortion access and reproductive freedom for people of all genders. Fight for rights, safety, and dignity for our trans community, including gender-affirming care. Meet the employment and economic security needs for people living with HIV. Elevate lifetime survivors' vertical specific needs, and elevate older and aging folk with HIV specific needs. Next slide. What are your concerns and how do you advocate for them at USCHA?
And Michelle, I can go ahead and take over from here if you would like me to.
Go right ahead, Barb.
Okay, thank you so much for that incredible run through around our demands. We went ahead and put in the chat by each of these area of demands where you can go to advocate for it at USCHA. And we will include this list in our follow-up thank you email for folks who joined us today. So you didn't need to copy it all down, but we just wanted to let people know that there are specific workshops and sessions where you can go and you can talk about each and every one of these particular points. And so now we want to hear from everybody else. What are your concerns? Are there some in particular that we have not elevated that you want to make sure people have on their radar as we're going to USCHA? Any concerns, areas we might have missed, or just topics that you want to bring up? Perhaps if you have some questions, we could do that now as well. If you want to just go ahead and raise your hand or come off of mute, now is the time that we have to be able to discuss with our audience and everyone who's going to be joining us at USCHA.
I know I saw Melanie's hand earlier. Melanie, I'm wondering if you still had a comment to make.
Well, when Ronald was talking about the House appropriations bill and the Senate appropriations bill, when it was side by side, you could see the drastic difference in what the Senate believes should occur and the House. Normally, when there are two separate bills covering the same thing, there needs to be a conference for compromise and hammering out the bill that's eventually going to go for vote. So looking at these side by side, even the Senate bill is really a cut because there's no such thing as flat funding. They call it that, but if you're getting the same amount and inflation has occurred and costs and services and all that have gone up, you're getting a cut. The House bill doesn't want any funding to be in place for those of us living with HIV. And so in the conference, hammering out a compromise, it's going to be drastic either way, because the House is not going to want to give up on what they want, and the Senate, they're going to stick their guns to get what they want. So it's going to be a real, advocacy. It's not just a call, it's not just a letter, we have to show up, shout out, and demonstrate, protest, because we need to be seen, not a phone call going into an office. We need to be seen with our signs and megaphones what we are talking about. They're trying to erase those of us living with HIV. Even in the HIV epidemic, it's focused on preventing new diagnoses. That's the main focus. They have all this other stuff in there, but don't be fooled. It's to prevent new diagnosis. And whatever else we who are living with can eke out to make sure we are healthy and can get some type of quality of life. Um, so, act up. We have to act up. We have to go back to the basics. We have to act out. We have to show up. We have to shout in order for those of us living with status neutral is trying to erase those of us living with HIV. Erase. They don't care about us. And when that EHE came out, I knew U equals U was no longer an adequate place to be, undetectable. We need a cure because they don't care about us. You need to be cured in order to be even thought of as people. That's all I'm going to say. So we have to show up, shout out, show signs. If you don't want to say anything, Barb, what's your toolkit? The hard copy or the
the demanding better?
No, not the bending better. Blank paper. There's regular printing paper, and then there's the one hard stock and
Yeah.
and markers. Write
Yeah.
stuff out and hold it up. You don't have to say a thing.
Yeah. Yeah, that's a great point, Melanie. Thank you so much. All righty. Anyone else want to share what they're coming to USCHA really ready to talk about? Feeling empowered to demand changes be made, people listen?
I'll just say that we on this presentation did molecular HIV surveillance in 10 minutes, which is not enough time to do justice to the ways that our concerns with MHS and our demands for the different kinds of policies that need to be put in place to protect the human rights and dignity of people living with HIV. It just wasn't enough time. So if you're going to be at USCHA, please come to the session on Wednesday on MHS. We're going to have a lot more time. It'll be more spacious. There will be more time for back and forth. So that's just a pitch for that.
Absolutely. Thank you, Kelly. Thank you, Kelly. Yeah. It is a complicated topic, but the reason why we wanted to introduce a number of them and not go as deep as we could have is because we wanted to make sure that folks who are showing up at USCHA and were a part of the alphabet soup of all of these acronyms had a sense of how it all fit together. And how to, yeah, go ahead, Martha.
I know we did not talk a lot about NIH and research. I know that there's going to be a couple of workshops on research. There's a saying that we have in the research world for those of us that are on community advisory boards, helping with research, is that if you're not in the kitchen, you'll be on the menu. I'm sure it's similar to something that we've heard. So something that's really important for all our populations is to make sure, especially for all women, is to make sure that we get engaged with research, get involved in research, and also are demanding better priorities. Some of those can be turned into research priorities to generate the data that is used to back up funding and so on. So look out for that as well, and look for opportunities to understand how research money is being used, or to question it, or to demand it.
Yeah. Thank you. Thank you, Martha. And just checking to see if there are other points that anyone would like to either ask a question about, make an additional comment, things that you're coming to USCHA specifically to advocate for, to learn a little bit more about, that you want to share with the group. All righty. I think it is people are done on this Friday afternoon. So as we said, we're going to go ahead and put out a huge email that'll have all of these links as well as the recording and the slides. We also are working on a booklet for people that has a lot of this information included that you will be able to link to and have at your fingertips. So if you're at USCHA and somebody comes up to you and they say, oh yeah, I am detailed with the ACL, you can look it up and you can say, okay, I know exactly where you're at. And I know that I want to talk to you about specifically, because you're with the community, the Administration for Community Living, I want to talk to you about HIV and aging. Those are my concerns. And yeah, we want to just make sure that everyone knows the pieces and how they fit together and have enough resources. One last thing, we're going to invite everybody to sign up for our PWN WhatsApp group. So if you fill out this form here, it's bit.ly/2023-PWN-USCHA. We will add you to our WhatsApp group so that you will have at your fingertips a whole bunch of community that you can ask questions for, meet up with if you're feeling some kind of way after a presentation, because sometimes indeed what happens is we go to these and they talk about people living with HIV as if we aren't even in the room, and it is problematic. And so please go ahead and sign up and we'll get you added to our WhatsApp group, but please feel free to reach out and to talk to anyone who was on, indeed, we are humans, not clusters. Feel free to talk to anyone who was on this webinar. I know that Martha, myself, Kelly, Ronald, and Michelle will all be at USCHA, and we are happy to think through anything. If something feels, like it was a little bit pinchy and problematic, trust your instincts. It probably was. There's a lot of horse manure that goes on at USCHA, unfortunately, and we are there as community to help support each other. And one last piece I want to add. There will be some protests. There always are at USCHA. Feel free to join in because this is how we make sure that people in power know that we are speaking up and demanding better for us and our community. And this is at a USCHA where Dr. Redfield was on the podium and was talking. And indeed, people were talking about clusters and trans and gender nonconforming data inclusion. And so when we get together, let's protest together, let's disrupt together, and let's demand that the voices of people living with HIV are elevated, that the voices, as Michelle said, and so many folks have said, that the voices of Black, cis, and transgender women are elevated and are the loudest in the room, and that we demand what our community needs to be able to do well, survive, and beyond just surviving, to thrive, because we deserve it and we demand it. So with that, I'm going to go ahead and close our webinar for today. Thank you everyone for joining us. Please, I know for some of you, this is your first USCHA and it can be intimidating. Find someone else, gather up each other, and make sure that our voice is heard, because it is so necessary, more now than ever. And with that, I want to thank my presenters. I want to thank Martha and Ronald and Michelle, Kelly for holding space with us also, and for everyone who joined us. We will see you at USCHA, and thank you again so much. And we'll give people a chance to sign off so we're not hanging up, booting people off. And once again, Martha and Michelle, Ronald, Kelly, thank you all for a fantastic webinar.
Thanks, y'all. Have a great day on purpose. See y'all, some of y'all soon.
All righty. Take care, everyone.
See y'all next week.
Yeah. Yeah,
Have a good evening.
USCHA.